to have a better outcome for our surgical patients and oncology patients with lung cancer. So this is the disclaimer. I have no disclosures to present. So let me start by just giving an introduction that management of lung cancer really remain a challenge over the last probably 30 years. Despite recent advances in medicine, in many aspects, there have been a very little impact on the outcome of lung cancer. We believe as surgeons that the surgery remains the best treatment modality for early stage lung cancer. Although early stage lung cancer is less common, especially in Saudi Arabia because of lack of screening, but now we are looking how can we, as the owner of patients with early stage lung cancer, improve the results. So let me take you through a journey. First, I want to highlight that lung cancer incidence is increasing and it's becoming the number 1 cause of death in Saudi Arabia. And it's increasing among men and women despite all the efforts to reduce smoking. Next, we as surgeons look to non-small early stage non-small cell cancer not only as the treatment modality. We are part of the diagnostic, especially if the minimally invasive intervention radiology failed, and especially now the need for a proper biopsies for molecular staging of that tumor. We are also part of the assessment, especially if the tumors are close to the main bronchial trees to stage and assess by bronchoscopy. And we have play a major role in assessing the lymph node status of those patients, although EBUS is now the standard modality, but in many cases, probably mediastinoscopy will also be needed. So we are really part or fully a part of the management of early stage lung cancer. So before we proceed with this, it's part of the, I'm sure everybody will come across that. We believe that staging of non-small cell lung cancer, especially the early staging, was very useful. It was really made of more than 150,000 cases that have been collected, and I was lucky enough to be part among the staging committees for the new lung cancer. I was responsible about nodal staging with other teams who were responsible about metastases and tumors. So when we chose a staging, we really want something to reflect the disease, can relate to the prognosis of that disease, and can dictate what would be the best treatment, whether it is surgical or non-surgical, and predict survival accordingly. It has to be internationally approved, so we collected data from really multicentric, and we made sure that it is simple to use and easy to duplicate. Next. Now, according to the new, what we noticed is that the tumor size is really very important. So if you compare it to the old staging, every centimeter matters. So that's why T1, which was 0 to 3 centimeter, have been divided into T1A and B and C, where every centimeter have a stage in the T. Same when it comes to T2, when the tumor is between 3 to 5, 2A is 3 to 4, and 2B is 4 to 5. And T3, we believe that it has a limit, so up to 7 centimeter only, and anything beyond this is T4. And when we talk about a tumor from 5 to 7, it's like other tumors who have invaded chest wall or pericardium or phrenic nerve. So it means the T really have a very important. And same when we spoke about tumors more than 7 centimeter, they are, even in the absence of lymph nodes, they behave like tumor who have invaded mediastinal and mesostructure, not just simply as a tumor as such. When we were discussing the nodal status, actually, we tried to differentiate between single node versus multiple node station, and between bulky and non-bulky, and between station 5 and 6 for left upper lobe tumors compared to others. But really, we didn't see the significance, so we maintained the original staging of N0, N1, N2, N3. But we changed a lot in the metastasis because now with the better modality, we really can tackle patients with early stage lung cancer, and then we discover a metastasis. Then it comes to an M stage, so it comes stage 4A or so. But we noted that if the metastasis is just pleural deposit or some pericardial effusion, they can have a good prognosis. Also, if it is a single Mets like brain, and if you deal with the two entities, really they do well, and accordingly it was subdivided. Next. So if you look to now, this becomes a bit complex table, and I think for non-physician people also belong to AstraZeneca, this is something you can keep always in your pocket. So stage 1 will be any early stage with node 0 up to 1A up to 3 centimeter and 1B up to 4 centimeter. But once it is 4 to 5, it becomes a stage 2A. Same if it is, so that was quite an early stage into that. So 1A and 1B and 2A. 2B was the tumors that actually from 5 to 7, so they remain as T3, or if they are T1 and T2, but with nodal N1. And this are the one in yellow. And I think this is what we're going to be focusing on, because this is the debate being, are we going to label those groups as early stage lung cancer and make surgery is the only surgical modality for treatment or not? More advanced cases, locally advanced like stage 3A and probably 3B, are actually a bit more advanced. And of course, the 3C and all lymph positive Mets stage 4, although, as I said, for M1A different from M1B and M1C, and that's why even stage 4 have stage 4A and stage 4B. Next. I'll take you, just not to show my age, I take you through when we started collecting this. I've been doing thoracic surgery for more than almost 35 years as a specialty into that. I'm showing you the one which was actually old one when we Martini is reported the biggest series of lung cancer at Sloan Kettering, and if you notice, stage 1 they had a big group where he did surgical resection, and if you see that the average 5-year survival was only 76. And when it was stage 2, which is again early stage, the 5-year survival was around 50%. That was really unsatisfactory result, knowing that the surgeon have gone in, removed all the tumor and achieved complete resection, but only 76 or 50% will survive 5 years. So what have we done new in surgery? We tried to do better diagnosis, better staging, better assessment, better anesthesia. We're using minimally invasive robotics, less morbidity, less mortality, but really did not do much until we started having tumor board and we became more aggressive and considering multimodality for those patients. Next. So this is the results when the staging came. If you compare it to the results I showed you before for Martini, it's almost the same. You know, stage 1, they had 1,500 cases and 5-year survival was around 60%. Same for stage 2. So really, we have not done much. Next. And this is even when we go by T1 and T2, you know, even tumors that is 2 centimeter or 2 to 3 centimeter, the 5-year survival was ranging between 50 to 60%. So really, there is something we are missing as surgeon. And so we believe that early stages like stage 1A, 1B, and 2A and 2B were purely surgical, while once it goes to 3A and 3B, it becomes a multimodality. And I want to question this as we speak. Next. What I did, which for some time ago, this is my own publication, we looked into the 5-year survival after complete resection of primary non-small cell lung cancer for 200 patients. And this was, you know, the best results. We had only 83% 5-year survival in stage 1 and 64 in stage 2. So there is, I'm losing almost 1/3 of my patient in stage 2 don't survive 5 years. So I did another study and said, what is the pattern after resection of stage 1 and stage 2 in lung cancer? Do they have local recurrence or they have distal metastasis? And when I did that, I found that majority have distal metastasis. That alerted me to say, then surgery alone is not enough.
Prof.
I cured the local disease, but there is extension.
Prof. Khalid,
So how can we improve? Yes.
can you, I think we are lacking one slide. Can you move the slide? Or Arwa?
Marwa, yes. We're lacking many slides.
Yeah, I think so. Yeah. Just,
Next slide, Dr. Khalid.
Next, yes, next. We've gone through all
yes.
of this.
Yeah, yeah.
So this is when we studied 5 years survival, and we found that only 2/3 in stage 2A survive, and the remaining don't survive over 5 years. It's a big amount, 1/3 of our patients. Next. So we looked into what is the cause, and as I said, the majority were distal metastasis, not local recurrence. That means my surgery was good to control the local disease, but was insufficient to make the patient survive because they developed distal metastasis. So how can we improve the results? First, screening. And I'd like to mention that AstraZeneca kindly started a pilot study in screening of lung cancer in Saudi Arabia with big funds. So this is part of their continuous service to the community and to the lung cancer. So thank you, AstraZeneca. We have now better staging. We do lymphadenectomy. We follow up the patient. If he develops mets, we do metastatectomy. And we're looking into that, but still we were short of improving the results the way we wanted to be. Next. When we started seeing sub-centimeter lung cancer, yes, we had almost 95 to 100% 5-year survival. When we started doing lobectomy by VATS, we improved the result a bit, and early stages had a good 5-year survival of 85% with very little morbidity and almost nil mortality. But still, you have a good amount of your patients, 15 to 20%, develop metastasis. Next. So even with robotic, really things did not change much. Next. So let me talk about what we do. Even when we completely resect the tumor, even if it is close to the bronchus, we do sleeve resections, and when we manage to remove all that kind of tumors locally in a very well controlled with pathological complete resection into that. We also have next, we have a lot of attention to the lymph node, and we emphasize that lymphadenectomy should be done for every patient and should be really assessed very well before and after. Because a lot of recurrence was actually at the nodal stage from our previous study. Next. And this is simple. The green are N1, which is hilar nodes within the pleura of the lung affected by the cancer. N2 is the orange, where they are in the mediastinum, but still on the same side. Once the lymph node cross the midline or go up in the cervical area, it becomes N3 and becomes quite more advanced. So one of the things we said is let us then look carefully into whether N1, N2, or N3 are involved, even with the PET scan, which gives good results, but not enough. Next. So we know CT scan have low sensitivity when it comes to lymph nodes. PET scan have the best and higher accuracy into that, but still we have good number of false negative cases, up to 21% of the cases. Next. EBUS, as I said, and transbronchial needle aspiration was done, and it improved the result, but not to a maximum. So we still sometimes use next mediastinoscopy and video-assisted mediastinoscopy for that. Next. So we looked into, when we reviewing the mediastinum, whom did we miss with N1, N2 disease? And we noted that if the tumor is more than 3 centimeters, or if the tumor is adenocarcinoma with high FDG, or if the tumor is central, or if there is positive N1, the chance that having N2 disease becomes high. And that's why we said even if the PET scan is negative, but if you have high risk patient, you have to do mediastinal lymph node biopsy by EBIS or by mediastinoscopy. Remember this. This study was done around 10 years ago, but have highlighted who is more early stage lung cancer, but at higher risk of having missed N2 or having malignant cells bypass the pleura into the extrapleural space in mediastinum and possibly in the circulation. Tumors who are central, more than 3 centimeter, mainly adenocarcinoma, high FDG, and if they have N1 disease. Next. From there, we said, okay, is surgery enough? Whether you're going to do segmental resection or sleeve resection is enough, or even if you add radiotherapy, is that enough, or you need to have an additional therapy to improve your result? Next. This is just an added slide that whenever the patient is not fit for surgery, also radiofrequency ablation showed a good result into that. Next. So we said, if I am going to do complete resection, but I know this patient is high risk, like the patient who have 3 centimeter or more, or central tumor, or high FDG, or have already N1, it means that surgery alone is not enough. And the only way to improve results is actually to add something. When the era of chemotherapy was there, we started something called CHEF with another company, which is EST. And it was multicentric, but we aborted it because the chemotherapy was given to the very early stage in high doses, and the side effects were high. Then the target therapy came, and I'm sure this will be well explained by the next professor after me. Next. And we started using target therapy in selected patients that maybe we will have. But I think even target therapy had minimal improvement of the result until the era of immunotherapy comes. And when we talked about this, we started to go back to our previous results we have done 20 and 30 years ago and said, or tumor that are central, tumor that have high FDG in PET scan, tumor that already have an N1 are really high risk of still metastasis. So we have, and I leave that next, please. I'll leave that to next slides. Yeah, I'll leave that to my next speaker, who's gonna talk about the immune therapy and their function of interruption of T cells through the BD1 and BDL1. So I'll go through that slide. And the next one, which indicate approval of this in multiple checkpoint inhibitors into that. And even our NCCN guidelines started to look into cases of early stage lung cancer and what else we can give with after complete resection and after incomplete resection when the margins are positive. Next. So that immune therapy era have really looked into, can we improve the overall survival or not? Because as I said, patients were not doing as well. So we wanted to consider preoperative or neoadjuvant therapy for those patients. And there have been good trials to look into 5-year survival of those patients and how the progression of the disease. Next, please. The other thing that we learned as surgeon is that we want to bring every case to the multidisciplinary unit that managed lung cancer, because our previous belief that surgery would be enough for early stage lung cancer, especially, as I said, the high risk patients with tumors 3 centimeter and above, and with N1 and central and high FDG adenocarcinoma, we may have the input of our colleagues on oncology and immune therapy diseases. The multidiscipline team is really in our hospital a very mandatory now. We as surgeons run a lung nodule clinic when all cases comes to us, but even if it is just 2 centimeter tumor with no evidence of any metastasis, has to come to the MDT and be discussed, and the options of neoadjuvant or post-operative therapy additional should be raised. So there is a pulmonologist, radiologist, pathologist, and medical oncologist and radiotherapist, plus the surgeon, in addition to our support team from nurses to palliative care team and administrator. So this is a picture of an important role being physicians and oncologists contributing to every single case in the. So in summary, I want to say the incidence of lung cancer is increasing. We are focusing now on screening, and I said thank you to AstraZeneca starting the first pilot study in Saudi Arabia. We have to have better awareness on how to manage it. The new staging really is good and reflecting the outcome. And we have to move from individualization of management to teamwork. So the role of MDT is important. And it's not a single decision, it's a collective decision. And that the best way to improve the outcome of lung cancer is that the management of lung cancer is done by a multidisciplinary team. So medicine today is not surgeon, but about multidisciplinary approach. And thank you very much.
Thank you, Prof. Khalid, for this excellent review and excellent points that we need to discuss after the next presentation. So I would like to ask Prof. Hochmeyer to give his presentation, Navigating New Immunotherapy Treatment Approaches in Early Stage Non-Small Cell Lung Cancer.
Many thanks. I can already say, dear friends, because some of you, especially the chairman, I know now already for a long time. And I'm happy to be with you today. And it's a really exciting topic. And I'm sure we will have a discussion. We saw from the surgeon the role that is important. And I will bring in the oncological view in this setting now. This is the disclaimer and information and disclosures. When I started, we treated all patients similarly. Everybody received chemotherapy. Nowadays, we have different treatment options. We have here on the left side the chemotherapy, well known, immunotherapy, also well known, but we mainly combine it in this situation. We have the targeted therapy, the new agents that we have, the bispecific monoclonal antibodies, also a very interesting topic. You cut an antibody in the middle, and then you put another part here from an antibody, and you can block two different receptors with one body. And on the other hand, you have the antibody drug conjugates. For example, trastuzumab deruxtecan would be something like that, or datopotamab deruxtecan, where we have already also relatively a lot experience in this topic. Also, you can combine the bispecific monoclonal antibodies and an antibody drug conjugate, and this is also some studies are running in this topic. Generally, lung cancer is not lung cancer anymore from the pathological side of view and how we interpret this data. Here you see just a recent publication, and it's completely like we see our patients in our center, that the majority of the patients have something in the NGS report that we can interpret, like, for example, KEAP1, STK11 are also sometimes co-mutations that we can find where we know we have and need an escalation of the systemic treatment. So we have some druggable targets. We have also targets that we can interpret. What should we test in the moment to get the right view, to get the right treatment for our patients? We published recently, also yesterday, in Lancet, a publication where we completely show that in another view. But important is that you have a close relationship with your pathologist, that he also summarize what is necessary in the report and what is not necessary. On the left side, you see these things that is a must, that you have to do. So in yellow are these things that should be included in the report. Here on the right side in blue and green, there are some emerging biomarkers where you understand the disease a little bit better and can have a reflection of the prognosis or a predictive marker, how long will the patient run on the treatment. Example, TP53 patients are running normally not so optimal on targeted therapy. On the other hand, Notch, for example, are not responding in KRAS mutations, KRAS G12C, for example, to sotorasib in this situation. Also here, KEAP1 and STK11, we treat now with the Poseidon regimen in the situation with tremelimumab and durvalumab and chemotherapy, because here we know the outcome is relatively bad. We have a registry in our center where we collected 800 patients in the moment for about a little bit more than 1 year. Now we have a data set of about 2,000 patients already. We are seeing around 800 till 1,000 patients per year in our center. And what we see, and I heard it before also, that in Saudi Arabia, the screening is also not really used in the moment. Unfortunately, we have the same situation in Austria. We just had with Corona more CT scans performed, and we had an increasement of the early stages in the beginning of Corona times. On the other hand, now we have here in blue and yellow, blue and pink, you see the majority of our patients are in a extensive disease or locally advanced situation, and only a few patients are really these patients in early stage. From our center, where we are extremely good, is that after the first contact to the histological report with the NGS, here we are very fast. It's only taking 15 days from the first clinical contact, 10 days biopsy, 5 days to the NGS report. So we can relatively fast decide what is needed for the patient. On the other hand, the patient, the awareness in the society is relatively low. Patients take a long time that they are showing up. Majority of our patients in Austria have adenocarcinoma, and squamous cell carcinoma is going down. Small cell also a little bit less than in the past. And here we will focus mainly on the adenocarcinoma. When we do an NGS test in our center, you see 50% have no results in the NGS. The rest are showing something. For example, we know that EGFR mutated patients are not responding that well to immunotherapy, so we are avoiding here immunotherapy. On the other hand, patients who have no druggable target or KRAS mutations, for example, are responding quite well to immunotherapy, and this is also something we can read out here. Is there a difference between early stage and later stage when you test in NGS? And we are testing really everybody, and we are publishing soon 500 patients comparing early against advanced stages. The result seems to be quite similar. There is no difference. Initially, I thought when we have small nodules that we do surgery, perhaps we have a higher frequency of EGFR mutated patients, or there will be a difference. But from our data, we didn't see really a relevant difference in this setting. Why do we test, and what is the goal of testing? You see, when you test and you treat, the patient is living longer. When you don't test, or you test but you don't treat, the patient is not living longer. Here is the treatment for later stage, how we treat nowadays in our center. You see a driver mutation is leading to the systemic treatment. So we are trying to use targeted therapy also here in the first line. For example, with HER2 mutated patients, it's not labeled, but we're using trastuzumab deruxtecan also already here in this setting, and also EGFR ALK-ROS1. All these patients are receiving frontline. On the other hand, when we have no driver, we're treating with immuno or immuno plus chemotherapy. But is this strategy only for stage 4? No. When here we are showing data that it's clear a difference, no difference if you use it in early or later stage. One of the first trials, everybody knows the ADAURA trial, OSI against placebo after surgery, and you have a clear overall survival for those patients who have received osimertinib in the adjuvant setting. EGFR mutation patient is ready after surgery. We give osimertinib here for 3 years, and then we have a clear overall survival. Is the 3 years right? I don't think that in higher stage patients that 3 years is enough, but here we have no data in the moment. And when I could choose 3, then I would treat these patients at least 5 years. The role of chemotherapy is here something special, and you see here with adjuvant or without adjuvant chemotherapy, there's no real difference. We are part of the NeoDaura trial, and we included here more than 16 patients in this trial, and we see that neoadjuvant treatment with OSI makes also clearly sense. Here just an example of a patient. The surgeon will say this is no problem to do surgery initially, but on the other hand, single N2 disease T3, it's not infiltrating the lower lobe, but it's relatively close. And what would you do in this situation? You cannot vote now, but based on the guidelines, you can also treat patients with EGFR mutations with a neoadjuvant strategy. You can do Pacific in this situation, chemoradiotherapy followed by durvalumab. You can relatively soon, hopefully, can do FLAURA, for example. FLAURA, the press release for FLAURA was already here, that you probably do chemoradiotherapy and then also including osimertinib in this situation when surgery is not possible. So we have a lot of different options in this situation. And we heard before the tumor board is extremely important, and here we have to decide based on this finding. With osimertinib here in this neoadjuvant setting, you see a clear remission already in the CT, in the X-ray, and also here you will say it was initially operable, but it would have been closed for the lower lobe. But after the neoadjuvant treatment, it's even easier, especially in this N2 disease. Here a little bit better to see here in the CT scan the non-small cell lung cancer with deletion 19, 3 months of 3 cycles of osimertinib, so around 3 months, and a clear remission. And then we did surgery. What do we see in osimertinib patients? We see that pathological complete remissions are extremely rare. I will show you data about pathological complete remissions after neoadjuvant chemo IO. Targeted therapy does not work in the same sense. Therefore, the maintenance treatment or the longer maintenance treatment, from my gut feeling, seems to be extremely important. Which data do we have for the neoadjuvant using OSI in this situation? Here's a trial from ASCO last year. 27 patients received OSI. And what we see here, that the major pathological remission rate is 15%. The pathological complete remission is 0%. So here we see we have a clear downstaging and a clear remission in the situation, but we don't have this pathological complete remission. A huge difference, what I will present very soon about the immunotherapy patients. And now we are moving to these patients who have no ALK, no EGFR mutation, where we have a clear druggable target, and we published at EACR and also in New England Journal of Medicine the important trial of the Aegean study. The Aegean study has here patients were initially resectable, so we can discuss who is resectable. This is a huge topic. Is a patient with a mediastinal N3 disease at the end also resectable, or can we say this is a clear irresectable situation. But we can also say patients are radiotherapy possible. These are wordings that we are using sometimes in the tumor board. Here in the study, principally these patients were resectable. With N2, normally we do a neoadjuvant treatment always, but here in this trial, they had to be as good as possible resectable. Durvalumab plus chemotherapy against chemotherapy, surgery, and then durvalumab in a perioperative strategy. So it's neoadjuvant and adjuvant immunotherapy. And from my feeling, this is clearly the best strategy. We have no clear data that we compared these strategies, stopping after surgery the adjuvant immunotherapy, but the trend and the clear sign also based on the label, this seems to be the perioperative strategy, seems to be the best strategy. In the NeoDARA, a lot of patients with N2 involvement were included, which higher tumor size with T4, for example. So this is a group of higher staged sometimes patients. A clear discussion we always have sometimes in the tumor board when we do neoadjuvant, do the patients lose the possibility to get surgery? So you see here, underwent surgery 80%. Some others didn't receive surgery, not in the trial, but they received surgery in another setting. So sometimes that we have to look very carefully at these trials, how many patients lost their opportunity to receive radiotherapy also when it's inoperable. And the rate of no local treatment is extremely low in this setting. And the result of the durvalumab chemotherapy against chemotherapy neoadjuvant and durvalumab in the perioperative setting is showing us a clear better event-free survival with a clear better hazard ratio. And you can see this was clear, and it had to be published in New England Journal of Medicine. There is no group where we cannot recommend this strategy in this setting. So the PD-L1 negative ones have also an advantage of receiving here this treatment. What about the pathological complete remission rate? This is in average those data that we see also with other compounds. And here we see 17.2 months at 17.2%. When we select the patients carefully, and this is our experience from our center, when you get rid of the ROS1 fusion positive patients or patients where we have a clear targeted therapy option, then these data are even higher, where we know that the PCR is leading to an excellent outcome in this situation. When we also include NPR less than 10% viable tumor cells, the outcome is here with 33 major pathological percent response rate. Also here, PCR group is seen in all groups, also in the PD-L1 negative patients. So we cannot select patients based on this finding. Here's the summary of this important Aegean study that is showing us the way where we should go, the perioperative chemo durvalumab strategy. On the other hand, we also saw at the ASCO the Keynote 671 trial, quite similar strategy with Keynote 671. Here, cisplatin, I normally don't use cisplatin, especially gemcitabine, for the squamous cell carcinoma patients. Here, I think the usage of this strategy is not optimal, but the data are completely comparable with Aegean. I can jump over that because I have to hurry up a little bit. And you see here also an event-free survival quite comparable with the data from Aegean. Here also the pathological complete remission rate comparable with Aegean, 18.1%, NPR a little bit higher with Aegean in this setting. Overall survival at the ESMO presented, here we already saw an overall survival benefit. I'm sure Aegean will show us also these things, this overall survival benefit, but it will take a little bit to see this data in this setting because Aegean is not mature enough in the moment in this setting. What do we know? The PCR patients are performing really excellent in this situation. So this is something, a good outcome, and we can motivate this patient, but also these patients who have no PCR, they have also a clear better outcome based when they receive immunotherapy. At the end, we don't know if chemoradiotherapy, also then immunotherapy without surgery, chemoimmunotherapy, so here Pacific study, the strategy of Aegean, or Checkmate, or all the other studies, the real strategy is not clear in the moment. Who is better for Pacific, where we use chemoradiotherapy followed by immunotherapy? Who is better for neoadjuvant chemo-IO followed by perioperative adjuvant immunotherapy? We cannot tell in the moment. So it's always an individual decision. The adjuvant strategy, from my feeling, IMpower 010 or Keynote 9.1 Pearl study seems to be not so optimal. Here, the event-free and disease-free survival data are not so motivating. Only for some subgroups, we clearly see an overall survival benefit, but the neoadjuvant the perioperative strategies seem to be really excellent. And here also from the ASCO, from the presentator, you see when you select the patients carefully and exclude patients where we have a good targeted therapy, then I think we will have a better outcome. At the end, I only want to show you some experiences from my personal, from our center, where you can see here a patient, a T4N1 disease. The surgeon initially said potentially resectable, but it would be much, much better when it would be smaller. Then we performed chemo-IO in this situation, and then we had a real hole there. So based on the RECIST criteria, we had a partial remission, and we said before we leave this hole there, this cavitation, we should perform surgery to avoid bleedings. And then we took out the tumor, and you see a T0, N0 situation. So based on the CT finding, we would not expect here a chemo-IO, after chemo-IO, a complete remission. Here also, this is a patient from the Aegean study, where the patient received chemo with durvalumab and then adjuvant durvalumab. You see here, huge tumor here, N1 disease T3N1. The patient responded in the CT scan, but then we received the pathological report, and it was a pathological complete remission. Based on the CT finding, we would say that it is a partial remission, but we would not expect a pathological complete remission. So the interpretation of the CT scan is extremely difficult. So at the end, we can say we can flip a coin based on the CT findings, what we see here in this situation. Here we have a 6% viable tumor after chemo-IO with partial remission, and here, like presented before, a complete pathological remission. We presented a publication in European Journal of Radiology recently to show what it can sometimes happen, that you have a nodal immune flare, that you just have lymphocytes, that you have just inflammation there, and the tumor completely disappeared based on the attack of the tumor cells, and then you do a misinterpretation of the CT scans. Also here, it can be a pseudo-progression. On the other hand, it can be a real progression. Based on the CT findings, I cannot tell you. Some newer patient experiences here, also a patient from the Aegean study. You see here a tumor here on the left side, baseline, and after chemo-IO, you see a new lymph node here, and also here lymph node, mediastinal lymph node, with not a real remission in the CT scan, in the PET-CT. And then you say, okay, this is now N2 or N3 even, based on this nodal flaring. And then we did EBOS and controlled that, and we only saw a sarcoid-like reaction in the situation. And then we said, let's do surgery. And then at the end, it was a T1A, N0, R0. So the interpretation of the PET-CT is really difficult. Also here, a patient who had baseline here, chemo IO, and then a remission. And you see here a PET positivity in the pleura where you didn't see it before. And I didn't know what I should do. Then I asked a PET CT specialist, and he said, I don't know exactly what that is. It can be an inflammation also. And we went for surgery, and this pleural reaction was nothing. It was just an inflammation there. Another case for the end, here a patient where we would do normally a Pacific regimen. On the other hand, the patient refused completely here radiotherapy because he wanted to have surgery. We went here in this patient with PD-L1 staining 1%, T4 and 0, completely occlusion of the main bronchus here on the left side. And you see here that normally we would perform here Pacific, but here we had a very nice remission, went for surgery in this situation after neoadjuvant chemo IO, and you see a complete remission also in the bronchoscopy. And we discussed here, is a surgery even necessary or not? And then we saw, based on the finding, a pathological complete remission. But where do we put these data? Where do we put these data? And I think Pacific has a clear space and a clear place where we have to use this regimen also, because the data based on the overall survival benefit, and I think this counts at the end, what is the real strategy with a hazard ratio of 0.71 is not something what you can throw away. And therefore, the discussion with the radiotherapists, with the surgeon is extremely important to find the right way for our patients. Lung cancer is not one size. Lung cancer treatment is not a one-size-fits-all strategy. We have to discuss each patient, and the exchange between all experts is extremely important. Thank you very much, and hand over to Riyadh or wherever you are.
Thank you, Prof. That was excellent review and very thorough. We will have like 10 minutes for